Good afternoon and welcome to UnitedTV. My name is Kemal Erkan. If you think your insurance company is paying your healthcare bill, there's a good chance you are wrong. And that's a misunderstanding alone explain why your costs keep going up. Today, we are going to cover all this for you. It's going to be the continuation of our session that we started a couple of weeks ago. And we left you with a video from last week. And that video actually is perhaps explaining a lot of things altogether. So we are going to be able to now look at this from the health insurance company standpoint and then see what role they are playing. Now, as we start with our session today, freedom of speech is not a constitutional right for me. It's deeply personal. So in this country, we should be able to say what we need to say, and that is the one thing that freedom of speech is protecting us. In my own work in healthcare and public dialogue through United Medical, I have seen honest conversations is essential. We build a reputation based on honesty and dignity. When you look at number of clients, physicians who's been with us for more than 20 years, that would kind of speak for itself. And that's what United Medical is, and that's what Kemal Erkan is. So anything and everything that we are going to tell you, and we've been telling you, is going to be based on the truth and the factual data. So that is one principle that we have. Therefore, that should be a reminder for those who may not understand what they see and the way that they process things needs to change. So that's why we are also here. Now, this is not specific for this session, but it's important. So we are kind of, if anything that we say is wrong, so you guys always can reach out to us or ask us questions in the comment section. But I want people to understand how we are spending our healthcare dollars and who is responsible. Last week, we started with the hospital side. Prior to that, with the high-cost patients, and now the insurance companies, and we don't want to make any of our partners unhappy, but we are just going to talk the truth and then explain what's happening. So Phil is going to help me with questions today. So Phil, how are you doing?
I'm doing well, yeah. Thank you once again for flipping the roles and taking the hot seat to answer some of our questions. You know, like you said, I know a lot of people listening, including myself, frustrated by healthcare costs, and it's hard to fix something that you don't fully understand. So I think that's why these conversations matter. So it's important, as an expert in this field, that you help some of us understand this. So but before we can even talk about rising healthcare costs, we need to make sure everybody, like I said, understands who actually does what in the insurance ecosystem. So can you explain for us the difference between an insurance company and a third-party administrator, and why confusing those might distort the healthcare cost debate?
So confusing part is reasonable in this one, because it's not that open to, like, even for myself, being in the business as in the medical billing in the beginning for several years, I actually miss a lot of things. And I'm like, it was 2012 was the awakening for me. I'm like, how did I miss this all these years? I started this in year 2000. That's 12 years. Now, I know public doesn't understand this. So, true insurance company takes a risk on those covered lives. So, when they are third-party administrator, we are going to reference that as TPA. TPAs don't take risks. But the confusing part is a lot of insurance companies are also TPAs. So when you, like in United Medical, for example, we purchase our health insurance from the insurance company. But same insurance company is a TPA for other employers who are, who have more than maybe 1,000 employees or 5,000 employees. So on their insurance card, it looks like if, let's say, Aetna or Blue Cross is the insurance, but you also see the section, if it's a self-funded plan, it will say who the employer is. So that's the part that actually is important, because I am pretty sure you didn't know this number before, but in the mix of the business of the health insurance, when we just look at any insurance company in Delaware and also in the United States, their mix of TPA versus actual risk insured group is 75% TPA, 25%
Wow. Yeah, I would never know
covered
that.
people. So that's that actually, and again, this is okay not to know this. I'm, openly say this was 2012. After 12 years, we are like, oh, this is why certain things didn't make sense, and then that's kind of like, oh, now it makes more sense. So that's the key. So understanding the actual dynamic and why they are separate is important.
So I guess now that we kind of understand who actually holds the risk, next logical question is what happens when cost inevitably rises? So who is actually paying more? Is it the insurance company, the employer, or the patient?
So on the TPA side of the business, it's the employers paying. So these are self-funded plans. Let's just put it in perspective. And since we used Christiana Hospital in our last week's episodes, we can use them from their employer angle. So Christiana Hospital is the biggest private employer in Delaware, and they're self-funded. So when cost increases, first the employer is paying. So, but if the employer has like these plans where you are responsible for X as an employee in that plan, your deductibles, your co-insurance, and other things, as this is increasing, the cost is increasing. Yes, employer is paying, but also employees are also picking up that cost. So it's kind of like in the TPA side, insurance company, the TPA, never pays the increase. So because they have zero risk. In fact, they are, they are charging their charging model, like their business model, how they charge the fee schedule for this TPA business is not based on employers' income. It's based on how much they spend. So the expenditure is the key. So if I am going to charge how much my charge percentage is going to be on your total expense, my motivation to reduce that is zero.
Yeah.
So that's not because I'm dishonest. It's just a good business for me to make you spend more money.
Right.
Right?
I mean, yeah. I mean, and eventually it trickles down to the employer. It could be other ways, wage suppression, things like that. So, even if employees don't see it directly, I think eventually they still end up paying for it, some way or another.
That's what it is.
So, again, that brings us to another question that a lot of people ask, and that's if the insurers are involved in negotiations and are supposedly to negotiate on behalf of patients and employees, then why haven't they been able to control hospital prices?
So this is, again, very important because so you live in PA and you are new to Delaware, right?
I am, yeah.
So let me actually just, introduce you to Delaware, right? So Delaware has 3 counties. Newcastle County is the main one. And by now you know which hospitals that we have here. It's Christiana. So we used to call Christiana like 800 Gorilla, but I don't know if that means anything anymore because they are making 1.2 billion profit in 5 years. So that Gorilla is really rich. We know that, right? This is 1-800 Gorilla has a lot of money. They are the number 1 player. So if I have the level 1 trauma with one hospital system, if I'm the insurance company, what chances do I have? None.
Not much.
So let's go to Kent County. Well, there's only one hospital system, it's Bay Health. So if I can I provide coverage if I'm an insurance company or a third-party administrator that's gonna provide coverage for those employees coming from the self-funded plans? I have to have a network. So can I do this without the major insurance company, not a major hospital, not being part of that plan? No way.
Well, it's true because in many markets, there aren't alternative networks, to choose from really. So, it makes it difficult.
So now this actually, I'll elaborate this a little bit, especially in the Newcastle County. We have another hospital system as St. Francis. St. Francis is part of the Trinity Health. Trinity Health is one of the biggest healthcare organizations in the United States, a lot bigger than Christiana itself. So now it's a Catholic hospital, and they lose money. Well, Christiana Wilmington campus is right here across the street, and then St. Francis is about less than a mile from here. So we talk about how much Christiana is able to make and the profits that they are making, but then now I'm just telling you that St. Francis is losing money.
Mm-hmm.
So why? Why is the key, right? So because one of them represents 90% of the business in Newcastle County. Most likely they have better rates from the insurance companies. That's that simple.
Yeah, and I think that imbalance isn't talked about enough. And then it's, like, again, unfair to the patients who want to maybe be selective in where they go.
So one reminder for those who aren't following this and trying to understand what we are saying. So one may say, well, what's wrong with that? Let's give you an example. So let's say I drive a certain car, like a certain brand, and I've been there for 20 years, same one, and went there multiple times. They know me, and when I go there, I probably want them to treat me a little bit better than someone who's the first time getting the basic entry-level car there, right? At the dealer. I'm just putting this in analogy so that people can understand the issue. Now, why can the hospital position themselves, right? So this is kind of like, that's a big question mark, but that question mark actually is very small. Actually, it's none, because we have Medicare and we have Medicaid in this mix of the business that people who are receiving services are funded from federal programs and the state programs. So it's not your money to make more money. So if I go to a dealer and like a car dealer and buy whatever I want to buy, and then because I'm buying multiple, then they treat me, that's my money, right? But on the other side, insurance or the hospitals, that's not their money. So this is the money that comes from your taxes.
Yeah.
So that's why regulation is extremely strict to control these types of things. Well, does that mean everyone is following the rules, or are there some loopholes that you can bypass these? Absolutely.
So you can see some of the leverage that some of these larger hospitals have, and that leverage shows up in contract language that the public, would hardly ever see or hear about. And so one of these things is called most favored nation clauses. So can you explain a little bit about that and how that affects healthcare costs?
So this one is interesting, because when I first used most favored nation clause in our ACO meetings, they looked at me, our providers, and some of our employees. They're like, "What the hell is he talking about? Like, this is like most favored nation is international, in the international business trade. Like, you have, let's say, with United States and Turkey, like you say, Turkey is most favored nations to United States. The trade is going to be from that country, and then we are going to charge them less for the tariffs and all that." So, however, this one also is in reality in the healthcare business with the insurance companies. So this usually comes from the hospital systems. So hospital wants to have a really good kind of base floor for pricing. Now, I'm not saying that every hospital is doing this. I'm just saying that this is what is happening, and there are cases. And the issue of which we are going to go into some examples. So when you tell the insurance companies that you cannot charge less than what you are paying me for others. So then what happens? Then I'm kind of I'm settling a new baseline.
Right.
Right.
Once the prices go up,
So,
they stay
but,
up.
But we are talking about it, right? So you are the payer, I'm the hospital. So Ethan is the other payer. Now Ethan actually has a mic, he can talk to us too. So now you are the second insurance company in this. So, or the second hospital, I'm sorry. So if we say, hey, you cannot charge him, your price level cannot be less. So then you are actually just having this really good pricing control, almost like monopoly, right? So you are getting together with other people in competition to you, then you are kind of almost saying that this is what the price is going to be.
It's like structural inflation. They're just kind of creating their own cost for things. That's why, a Band-Aid could cost hundreds of dollars, or an IV bag, $250. Things that are dollars to create. But
So now the other thing is that you are making this more difficult for the competitors. So now they have to actually, they have to pay. They have to compete with what you are doing. And if I'm Hospital A, setting this term, then Hospital B is not part of it. So then they are kind of sucked into this
right.
without their knowledge. So the one of the things that I get, one of the messages from our people with the TPA business, and one really important part, and one of our directors messaging me, thank you, Anthony, for this. So why also it's important with the TPAs, the state retirees, state being the biggest employer. So Christiana is the biggest private employer, but state of Delaware is the biggest employer and has a lot of retirees in there. So they're also part of this too. So this is like impacting their pension and everything. Like everyone is going to now pay more, and the person who's in that group, the employee of the state, the retiree of the state, is going to be impacted by the same thing.
Right.
So this is again affecting everyone altogether.
Well, I think that's what's especially frustrating is that like lower cost care exists. It's not non-existent, but it's not always rewarded. Independent practices deliver care at a lower cost, but they get lower reimbursement. So why do insurance contracts often favor large hospital systems over a low-cost outpatient provider?
So before we go to this question, if I can just take a minute here and then go back to most favored nation business, because this is really important. So people may think that, hey, what the hell is he talking about? So I have a couple of examples. They are not part of our regular question, but I wanted to kind of provide some perspective for this, for people to better understand what it is. So there is one case that happened between 2010 and 2013. This was with Blue Cross Blue Shield of Michigan. And this is the result of this was Blue Cross of Michigan permanently prohibited from using MFN, most favored nation, and MFN plus clauses with hospitals. So hospitals were free to negotiate lower rates with competing insurers without penalty. So
that's
then
like common sense,
right? So, but like the common sense is not common practice.
No. Yeah.
So, and now the Michigan has a law that state level legislation banning all most favored nation clauses by dominant insurances.
Wow. Yeah.
So now the other case that I want to share, this one I don't know if there was a actual dollar amount, if there was a fine, but the next one is interesting. Sutter Health, California, 2014-2019. This is a 575 million settlement by Sutter Health. So Sutter was forced to end all or nothing contracts anti-steering provisions and anti-tiering clauses, and insurances regain the ability create tiered networks and direct patient to lower costs. Now, one of them is the insurance company, the first one. The other one is the driver is the healthcare system. So it can be used from both.
Right.
So it's not just one-sided. So this is kind of really, like when I first read these cases, it was maybe 7, 8 years ago, maybe, so maybe a little bit more. I was shocked. So because we know how the law is here, like, and then you know that like companies like us, we care about, yes, there's the law, but then we also care about having a compliance with this. And it's not like we are some like New Jersey, Italian kind of supermarket business, so they can do stuff under the table. I'm sorry for all the Italians, they can't sue me, but this is not that. This is a healthcare business. You wouldn't think that they would be able to do these types of things, and you wouldn't think that they would be even actually think about these things, but they do.
Well, and it's tough because, we work with patients, our providers work directly with patients, and they hear the frustration, and the patient doesn't often understand, why costs are so high, and they don't understand the complex details, and they don't understand that there's these hidden clauses in these contracts, between hospitals and insurers and all this stuff. And so it just, it becomes frustrating, and the people who make those decisions don't have to deal directly with patients also often.
Absolutely. So this is also, I think, our channel from that point for specifically for this issue. That's why it's really important for us to be able to make this available to the public, so it's easy to understand, and like they don't need to read what I did with all these things all these years. So they know that this exists. So this is a real situation. It's not like some game that we are playing. Or now we are going to go back to your question.
Yes, so just fast forwarding to that question, why do you think that insurance contracts favor the large hospital systems over the lower cost outpatient providers?
So if we are saying that why they are not kind of taking patients from these hospital systems, like the reduced to cost, right? That's kind of, that's not easy. That's not easy because they are kind of sucked into this relationship.
Yeah.
So now I'm going to kind of, maybe I'll do this a little bit earlier this time so then you don't have to repeat the question. It's all about the relationship that you have and the dynamics that you have in these settings. Again, we are using these names just so that people can put them in perspective. So we just mentioned Christiana Hospital being one of the biggest hospitals. By the way, Christiana is probably in the top 20 in the nation.
Wow.
So they are extremely large from that point. Now, then, well, we also mentioned that Christiana Hospital is the biggest private employer. So what happens if I work with Aetna or Highmark? If I'm the Christiana Hospital, now first I have a relationship with them with payer and the facility. So they are the payer, so I'm part of their network. So we have a participation agreement, facility, right? It's almost like similar to what we have with United Medical and United Medical ACO today. So I still have to be, like when I refer insurance companies, I call them as our partners. Now, going back to Christiana as being the biggest employer and having a self-funded plan, guess what Christiana is to Highmark? The client. So now the relationship is evolved, and now the dynamics changed. Now I have to be kind of nice to you if I'm hypothetically, okay, if I'm Christiana Hospital, I can push you on the payer contract to pay me more, because if you don't, maybe I'll take my business elsewhere. 3 years ago, the TPA plan for Christiana Hospital was Aetna. 3 or 4 years ago, so that changed. So that can change, and they do change. They shop around, I guess. So, and one of the things, the rumors that we had that time, with when the Aetna was a TPA, Christiana told Aetna that you cannot have any relationships with United Medical ACO in the value-based settings. I really want them to sue me for this too, because I have this in writing. So, from Aetna. Now, think about this. I'm using my power because I'm the biggest client for you, for Highmark, for Aetna, for United Health. And then I have to still negotiate the other side of the business. So this relationship is not a clean one. So, I just want people to kind of have fun a little bit. So like you have a prenup and you have to be with someone for 10 years and give that person for 4 kids, and two of them have to be boys, and then they need to be 18 before you can divorce and get anything, and you are in a really bad relationship. That dynamic probably is here.
Yeah.
So just so that people can see, like Ethan now pays attention. Thank you. So no prenup. Okay, so you should.
Well, it's unfortunate because it's, efficiency isn't what's being incentivized. And you would hope that would be what kind of drives these decisions, but it's not.
So, 2012, when I had the awakening, so I was like, oh, like all this is happening. This is Phil. This is one of those times I felt I didn't get what was happening in the meeting. The meeting was in the Medicaid office with 12 people, my lawyer, John Donnelly, and one of our cardiologists representing United Medical ACO. And the other side was one of the insurance company's medical directors. And we were there, and you kind of now get to know me a little bit more. So I try, when I know something that needs to be done, I try extra hard. So I'm like, we need to reduce costs, right? So
you don't have any problem speaking up.
And I put the right people in the room. Okay, so this is all good. And then the insurance company medical director said to me, I'm going to give his name because he's in my book, but I'm not going to mention the insurance company. Dr. Kaplan he said, you are trying to hurt my business. I'm like, Dr. Kaplan, how is that possible? I'm reducing your cost. And he's like, you don't understand how you make money, where you make the money. And like, no one is actually telling me. Even my lawyer didn't say. He's a healthcare lawyer, and he's a good one. Like, no one is saying, hey, this is how it's being done. So I go to my office after that meeting, processing everything, and after a little bit research, realizing that they are getting paid based on their expenditures. So if I'm reducing the cost of Medicaid, I'm hurting that insurance company who's contracted to do the Medicaid business, MCOs. So now their charge is going to be less. Their percentage is same, but the expenditure is less.
Yeah.
So this is 2012. That was kind of like, oh my God, I'm in this Illuminati and I don't know what the hell is going on. I was like the Tom Cruise in Ice White Shot, but taller. So Ethan didn't watch that movie.
I have seen that one.
You have to. So it was just so bad. I'm like, okay. So then I pushed that. I said, well, that's why I'm able to speak to this all in writing. I said, I played dumb. I said, hey, I didn't know this. How is this? Like, why did you guys say anything? Then I have his responses in writing. So this is real, and I can show it to you after this session. So this is just kind of like the dirty side of the business. So interest has to be there. So everyone needs to, like, if I'm reducing the expenses of the contracted party, then my income shouldn't be reduced.
Right.
So I think that's something that's changing and impacting the motivation of these businesses.
Yeah, it just all seems backwards from a cost control standpoint. But even beyond the prices themselves, as you've just explained, the system is incredibly complex. There's thousands of plans, rules, billing requirements, as you are an expert in. So how much of healthcare cost inflation is driven by this complexity? And, I don't think the answer to this will be the patient, but, who stands to benefit the most from that complex system?
So I think the overall, the meaningful portion of the U.S. healthcare cost is administrative stuff, like the overhead, administrative overhead. This is with coding, billing, claims, edit, denials, prior authorization, eligibility checks. If you know this whole process, and with the project that you are working, you probably can now see what it is. It's very difficult for the office to understand what it is that they need to do. Like the patient has Medicare, but then they have Medicare Age Advantage. So when they check Medicare, it shows active. And if they are not a little bit good at their job and then question what type of Medicare they have, they can miss. So if they miss that, then they're going to get a denial. Then AR is going to be involved. And then it's a lot of work that it's part of that is on the administrative side. But I think this whole utilization management and the claim operations, and I have a couple recorded phone calls with like Aetna, 59 minutes. I'm on the phone with someone in India. They transferred us to 5 different places. No one knows what's happening, and 59 minutes to find out one claim status, like the claim should be paid, has the prior authorization. Now they want us to call someone, so someone needs to make sure that this claim is rejected. So that's what we do. So then you take actions on it. We have to because people don't believe me, like then we record it, like 59 minutes. You're on the call with one person, and then when you ask them second one, they're like, yeah, we can only answer this because it's already 59 minutes. So that's explain the cost altogether, and why, what hospitals like these days, they have case managers, they have utilization managers. So they are constantly in touch with the insurance companies to get authorizations. So someone in the ED needs to go to the floor, that means they need to be admitted, and they have to get the authorization first. So the authorization means I have to sit down and then explain someone, hey, this is what's going on, these are the conditions, and patients in the ED needs to be, like, they are not trusting the physician to make that decision, because they have every right to not to trust the hospital system. Because if they are putting the patient in the admission and it's not needed, then they're going to overpay, and then hospitals are going to overcharge. So, but this distrust is also creating more work and more costs for everyone.
Well, and including, especially the smaller physicians, they have to make sure they put in the right insurance codes and all that things, and a lot of them, all they want to do is just treat the patient, make sure that their patient population is healthy, but there's all these different things that they have to do to make sure that insurance is covered and all that stuff. Yep. So it just seems like it's a lot of cost without much clinical value, which is the complexity of the system.
Absolutely.
I think one of the most visible examples of this complex business model we've been talking about is prior authorization, which providers will sometimes argue that all it does is delay care. Do you think prior authorization actually reduces healthcare costs, or does it just shift the cost and burden onto physicians and patients?
So it's a filter. So it does help to reduce the total number of cases, perhaps, like unnecessary utilization. Just
kind of manages volume more than price.
Like not everyone needs to get an MRI because you have some, like you have shoulder pain. Oh, let's get an MRI. No, unless you have fever, you shouldn't get an MRI. But then if you are getting it and someone is paying it, so insurance company is going to ask you, okay, let's go through this prior authorization process. So that may reduce, because also we are also at fault, the patients. So we want to have an MRI.
I agree, yeah.
That's the dumbest thing. Like, for example, right now this room looks clean, right? If you put one of those, what do you call them, in the blue lights that shows all the germs and dirts.
Oh, yeah.
Black light?
Yeah. So there's a lot of stuff going on. I don't need to see them right now because it's okay. We are functioning. So that's what MRI does. MRI is going to like anyone. Like if we check our three of us, right? Let's do a shoulder MRI together. We are going to find something wrong with it because it's just looking at it to a level where anything and everything could be wrong, but it's not an issue. It's going to say, hey, I think you have a little problem there. So, no, that's not.
Well, it's
you
not a
don't need it.
life-saving issue. I think
So it's going to say, hey, did you do PT? And then it's going to say, did you try muscle relaxer? Did you try X, Y, Z? So, yes, it does reduce the unnecessary utilization. What it doesn't help is the high unit prices. So this is important. Which I believe what Highmark is doing these days with the surgical elected surgeries, I think it's kind of fixing this issue. But I'm going to give you a different example on this one. If you look at the cost of MRI, and if it's done in a private setting, it's like an outpatient. The radiologist is the same guy, same education, maybe in some cases even better. And then you have same procedure done in the hospital. You are going to pay about 5 to 7 times more. So I can get the authorization, but if it doesn't say where I need to get it, it doesn't limit, then I still get the expensive one.
Yep.
Right. So that's kind of like it's not a quick process. Insurances also are struggling to approve or process them in a timely manner. So in our surgery center, some cases takes 3 to 4 weeks. So why?
Yeah.
Right. We have all the EMR and all the access and everything is available to everyone. Why do we have to spend 4 weeks to review a chart? And then, like, oh, some nurse didn't do it correctly, and then now they're going to reject it. I have to appeal and need to wait for 30 days.
Wow. Yeah. So
That
just
delays the
drags it on
care.
even more.
That delays the care. So this is kind of becoming like a weapon for the insurance companies, and I think they are more strict when it's an insured group, like if it's the insured by them versus if it's a TPA.
Yeah.
So on the TPA side, they're not as strict. On their insured population, they're kind of like, no, you can't do this, or oops, denied. So you need to, and this is happening. It's not like big percentage, but maybe 10 to 15% is still in that.
Yeah. So yeah, you can see the reasoning behind it, but is it being used reasonably? Probably not. Another major shift people may not realize is who actually owns what in healthcare now. Many major insurers own physician groups, pharmacies, or even the intermediate companies that are supposed to separate the two. So again, does that lower the cost, or does it simply just change who controls the revenue?
Well, the video that we played last week was explaining this ownership and how the relationship is so kind of like kind of complex, so that everything is hidden under one big platform that it's kind of like my ecosystem. Like that was the CVS ecosystem. I have the pharmacy, I have the providers, I have the insurance company, I have
I think AOC said they called it vertical integration. I gave it a cute name so people think it's working for them. But.
Right. So like, a couple of my doctors last week, they told me that they didn't know CVS owned Aetna or Aetna owned CVS.
I never knew. Yeah.
So like then there are 2 other providers, physicians told me that. So because of that, it's kind of like if we don't have a clear borders between these conflict of interest businesses, then you can build up your expenses and control the expenditure if you are on the insurance company side as a TPA. If you are the hospital system, now hospitals are, saying that, oh, we have so many outpatient facilities, so we are also like now the primary care office. Right. No, you are not a primary care office. You have residents seeing patients who are getting fully paid. So any residency program right now is having their patients, like if Christiana Hospital has family residency program, which they do, if you go to the Christiana Hospital as a PCP, you're not seeing an actual physician yet. You are seeing a second or third year resident.
Mm-hmm.
How is that okay? So I'll give you one other thing. This is, although it's with the insurance companies, but this is kind of interesting. On the surgical side, when I was in charge of surgeons for emergency care, one thing that came to our attention was the consent form. So because someone challenged the consent form, and it didn't say residents can do the surgery, well, guess what? Residents were doing the surgery. So you may think that I'm going to go to the hospital and I have this. If it's an emergency, that's different. Yeah. But if it's not emergency, chances are some resident is going to do your surgery and you are going to pay the full price. And yeah, you see the surgeon as an attending, but he or she may not do the surgery. Mm-hmm. Now, would this be needed for the system to work? Yes, but I don't want. I'm paying my insurance. I don't want some residents to operate on me. Yeah. Do I have a choice? Yes. The consent forms used to say residents couldn't make it, and 2015, I believe, and still I have these in writing. No worries. And they said, well, we need to change this now that residents may be doing it. So you're signing a consent form when you have emergency. Let's say, I always use the family members. Your mom's in the hospital, and then someone is asking you to sign a form. Guess what you do? You don't read it and you sign.
You sign it right away.
And then that signed consent form that now says residents can operate on you, and you have a consent.
Right.
So
but what are you going to do? Like take her out of the hospital?
Right. So this is why this relationship between the different segments of the healthcare system needs like clean borders. Mm-hmm. So like I cannot, like we own a surgery center, but I'm not an emergency room. I cannot operate on emergencies because I know what I'm able to do in there. But if I don't have any limits, so on the weekends we'll open the shop for, okay guys, we can do emergencies now. No, that's not how it works.
Right.
So any hospital system should also separate that side of the business and should be it shouldn't be non-profit. As we know that.
How does it affect those decisions? They prescribe you a medicine that you're going to go pick up from the pharmacy that they own. They're going to send you to a physician that they own.
So they have their own pharmacy in it. So they have their own lab. They have this is just like everything makes so much sense when you see the whole picture.
Right.
If you look at it from one angle with one perspective, that's not the truth. So, but if you just take a step back and look at the whole thing, and in that, everything is so clear. That's why, if President Trump wants to put me in charge of the healthcare system, I can fix the issues in 12 months because I know where the problems are. You need to separate the players. So, or the next president in 2028. So,
you hear that? We're taking applications. All right. So, this was a great conversation. So we're heading now to our last question here, but I think everything we kind of talked about, brings us to the core issue, which I think is the lack of transparency, between all of this, none of it's shared with the patient. All these healthcare contracts are confidential, more than likely that's to shield them from scrutiny. But what type of things, if the public were to see, do you think would fundamentally change then the conversation overnight if, people could see what's going on?
If we assume that people are reading and watching and researching, for them to know like the allowed amount versus charge amount for certain services and where it's paid and how much is paid in one setting versus the other one would definitely be a game changer. Any restriction steering the lower cost providers, patients from those types of agreements, they are in place still. Just because it's not out, it's not outed yet, doesn't mean that they don't have it. So these things may still have, we still may have these in place, so someone didn't just, challenge them. So that's, definitely, just to add an example that I give you, that's definitely happening, either in writing or verbally agreed. So, but it's happening. So we still don't have commercial Aetna value-based contract. This is 2026.
Mhm.
You know when we started talking to them? 2014.
Wow.
So
12 years.
that was one of the first one
Yeah.
that we approached, and we have the Medicare side of it, because on the Medicare side of it, they want the value base, and then they want to put a lot of work on us. Fine, but on the commercial side, Christiana said, "Don't do business with United." And then guess what Aetna did? They didn't do business with us. So, but now we are fixing that, hopefully, before Christiana changes their mind and then go from Highmark to Aetna.
Yeah.
So the other thing is the price transparency that we mentioned, not just the allowed amount, but now there are government sites where you can go and see how much this hospital or how much this provider costing you, how much this facility costs you. So just research. I think that could definitely be a game changer for people, because more people need to know where the money is being spent. And last week I made it very clear: physicians are not getting paid, or they are not getting more every year. So, and I shared the fee schedules for physicians. In fact, Medicare fee schedule went down. So this is between hospital systems, facilities, for the technical and lab studies, and these are hospital-owned places, some insurance companies. So that's where the money is being spent, and that's more people needs to be aware of these.
Oh yeah. I mean, they say sunlight changes behavior. You know, shine a little light on everything. So I think this transparency would definitely help reset the entire debate. You know, and that's why it's good to have these conversations so that people can be a little bit more, you know, educated. Feel free to email your state official, you know, about if you want changes. But, you know, I definitely learned a lot here in these sessions.
And we will try. I mean, we are not going to, we covered these in so many different ways in the past, but now we are doing it a little bit more with a better structure, you know, as we get better delivering these episodes. So I thought it was important for us to just cover these again with some updates. So this is going to be important for everyone. And like right now, I believe Matt Meyer, Governor Meyer, did almost finalize the budget. There are some increases, and we are going to invite him to come and do the state of the state presentation for us. John Carney has done that in the last 3-4 years. So hopefully we'll be able to provide more information. Now we have, before we close for today, we do have an announcement that we'll probably repeat this couple of times in the next couple of months. The 29th Eurasian Economics Summit is going to be on May 9th. I'm sorry, let's just take this again. So the 29th Eurasian Economic Summit is going to be on May 11th, 12th, and 13th in Istanbul, Turkey, and this is going to be our second year attending. And this year's focus is the planet running out of water and green dialogue. And this event brings 44 different countries, more than 800 people last year. And the important thing is having the dialogue between different cultures and working for the same goal is the key. And this is a very important event, and we're hoping that this year is going to be even better than last year. And this is again the 29th Eurasian Economic Summit by Marmara Group Foundation. So we'll see everyone in May. So and that's kind of what we have for today. We are going to have our Bariatric Friday in 10 minutes, I believe, and that's going to be with Dr. Erkan. So until the next time, please stay united. Bye-bye.